here. Thanks for continuing to come to this meeting. This morning, we're incredibly lucky to have two incredible guests and close colleagues and friends, Michele Deitch and Alycia Welch. The two are I'm not sure if both of you are giving the talk or if it's just you, Michele. So
No, it's both
you're
of
both
us.
both of you. Okay, good. So both are at the University of Texas, Austin, and run the Prison and Jail Innovation Lab. They're part of the law school. Michele Deitch is a distinguished senior lecturer and director of that innovation lab, and Alycia Welch is the associate director of the innovation lab, and, and they are going to be presenting their new report that they did for the ACLU and a little bit in partnership with the ACLU's National Prison Project, Trapped in Time, the Silent Crisis of Elderly Incarceration. Take it away, guys.
Great. Well, thank you so much for having us, Bree and the rest of the team. We are really delighted to be here with you today. As Bree noted, I'm Michele Deitch. I'm the director of the Prison and Jail Innovation Lab. My colleague Alycia Welch is the associate director. I also am a distinguished senior lecturer at the LBJ School of Public Affairs, and I've been working on criminal justice issues my entire career with a focus on prisons, conditions of confinement, and the treatment of people inside and ways we can strengthen oversight. Alycia has a long history of working on these issues as well, primarily on issues related to women, mental health, and reentry. Anyway, we are delighted to be here. Alycia, if you could switch the slides there, please, and next one, please. Okay. So after a brief introduction to our research project and the report that we wrote, we're going to identify the policies and practices over the last several decades that led to the growth of the elderly incarcerated population. Then we're going to explain how we conducted the research and the limitations of our findings before we provide you with a profile of elderly people in prison based on the data that we gathered. From there, we'll identify the harms that elderly people experience in prison and identify the, excuse me, the fiscal costs of incarcerating so many aging adults. And finally, we're going to present our detailed set of recommendations to reduce elderly incarceration, support successful reentry, and protect those who remain behind bars. Alycia, if you could switch, thank you. So this research project was a partnership between the ACLU's National Prison Project and the Prison and Jail Innovation Lab, which we call PJIL. And it was the goal was to update the ACLU's 12-year-old report, which many of you have probably seen over the years, called At America's Expense. After a year that we spent researching and writing, we finally released the report called Trapped in Time, the Silent Crisis of Elderly Incarceration last September, and we were delighted to get that out. If you want to look up the report, you can find it on the Prison and Jail Innovations website. It's pjil.org, and then you go to the Publications tab and click there. Okay. Next slide, please. So before we can understand population trends, it's important to understand some of the history and how did we get here. So tough on crime laws that were primarily passed in the 1990s, such as mandatory minimums and three-strike sentencing laws, truth in sentencing laws, the abolition of parole, and the increased use of life sentences. Those were policies that significantly increased the length of time that people were spending in prison. And those policies have kept people in prison for decades. Now, while current arrest patterns do play a minor role here, the primary driver of elderly incarceration today is the accumulation of long sentences that were imposed during that era. So, in this section of the report, we're going to focus on answering four core questions. First is, who's incarcerated at older ages? How large has this population become? How long have people served in prison? And what types of offenses are they convicted of? And I should mention that our goal was to have this profile of information available so that everyone's talking about using the same information. It provides a baseline that we can understand the policy issues. Okay, switch, please. So before turning the findings, I want to briefly describe how we conducted the research for this report. So to analyze national and state level population trends and demographics, we relied on a combination of publicly available data from the Bureau of Justice Statistics, from public records requests that we did requests to all 50 states, and from publicly available financial reports from state departments of corrections. So it was a very, very comprehensive look at the available information. Our analysis focused on people aged 55 and older who are incarcerated in state and federal prisons across the US. And to be clear, we did not include people held in county jails. It was just prisons. Now, this approach allowed us to assemble the most comprehensive national picture that's currently available about aging in US prisons. But it also revealed how limited and inconsistent the underlying data remains. So, as with most analyses that rely on publicly available data, our findings are shaped by the limits of the data itself. The data that we used for our analyses were not collected or reported consistently across states or over the years, which did affect our ability to make precise comparisons. For example, age is often reported in broad ranges rather than single years, and many data sets don't allow age to be analyzed alongside other key variables like offense type. Our findings are also limited by a lack of uniformity on key terms. States define violent and nonviolent offense categories differently, and each state's corrections department uses a different age threshold to categorize someone as elderly. So someone who's 55 in one state may be elderly, but 50 in another state might be elderly. And because corrections agencies don't report per person costs by age, our fiscal estimates relied on overall department budgets and population counts, meaning that they're very conservative estimates, and they're very likely underestimates of the true cost of housing elderly people in prison. So those limitations that we've just laid out don't undermine the trends that we identified, but they do underscore a much larger and important issue, which is the lack of consistent, transparent, and age-specific data that's reported by corrections departments nationwide. So with that context, let's turn now to the numbers. So since 2000, the number of incarcerated people aged 55 and older has increased more than fourfold, from just over 42,000 in 2000 to more than 186,000 in 2022. This is not a marginal shift. It's not an accidental shift. It reflects an accelerating trend that's driven by policy decisions, such as the ones I mentioned earlier, that are continuing to shape the US prison system and the population of people held there. As of 2022, people aged 55 and older make up nearly 16% of the US prison population. So there are about 1 in 6 incarcerated people. Now, this map shows that this phenomenon is not evenly distributed across the country. It really varies by state. So in places like New Hampshire and Massachusetts, elders comprise more than a fifth of the prison population. But in other states like North Dakota or New Mexico, they account for far less. Importantly, the states with the largest prison systems, such as California and Texas and Florida, they don't necessarily have the highest percentages of elderly incarcerated people. That's not because they incarcerate fewer elders. It's probably because they incarcerate younger people at very high rates, which keeps the elderly population as a smaller share of the total. Now, in smaller states like New Hampshire, where they have lower admissions, it means that people sentenced decades ago remain incarcerated and they age in place. And with very limited prospects for release, those populations continue to grow older with very little turnover. We also examined the race and gender profile of elderly people in prison. The headline finding here is that at the national level, the elderly incarcerated population looks very similar to the overall prison population. The elderly incarcerated population is overwhelmingly male, and their racial composition mirrors that of the broader prison population. But there's a notable difference that we found at the intersection of race and gender. Among elderly women, white women make up a much larger share of the population than they do in the prison system overall. And that's a pattern that we don't see among elderly men, where their racial distribution more
Ah,
closely tracks the general incarcerated population. So the next thing we were asking ourselves was, how long are incarcerated elderly people spending in prison? How long have they been there? So we used available BJS data, and that allowed us to estimate that as of 2021, more than half of incarcerated people aged 55 and older have served at least 10 years in prison. Over 18,000 people have served more than 30 years, and nearly 16,000 have spent more than half their lives in prison. The point here is very simple, and that is that many incarcerated elderly people have been there for a very, very long time. But then the next obvious question is, well, how much of their sentence does that amount of time represent? And here we had to rely on just one state. Texas is one of the few states that provides data on the average percentage of their sentences served to date by the elderly. So we focused our analysis on Texas. And this figure shows that more than a third of elderly incarcerated people in Texas have served at least half of their sentence. And that doesn't include life sentences. We'll come back to life sentences in a moment. But because sentences in Texas are so long, even serving less than half of a sentence often means that they've still been in prison for decades. So that figure underscores the point that many elderly incarcerated people have already endured a substantial amount of punishment. So let's look at life sentences because there's so many people serving life sentences. This figure analyzes the amount of time served by elderly people serving life sentences in Texas. And we found that the vast majority have already served more than 20 years. And hundreds of them have served 40 years or more. And some have been incarcerated for literally half a century or longer. So when you look at those three figures together, these last three charts, it raises really fundamental questions about proportionality and public safety and the purpose of continued incarceration at advanced ages. So the next question is, well, what kinds of offenses are elderly incarcerated people convicted of? Why are they incarcerated? So the most recent available year for which the federal government has data was 2016. So we looked at that data. And as of that year, about 70% of incarcerated people aged 55 and older are classified as having committed a violent offense. About 30% are incarcerated for nonviolent offenses, which includes drugs, property crimes, and public order crimes. But it's really important to emphasize that the label violent obscures critical nuance. It fails to reflect the person's role in the offense and the degree of danger that they pose decades later. But despite the fact that violent doesn't mean violent in every single case, this label is the reason why so many elderly incarcerated people are still in prison decades later, decades after their offenses. Now, this figure underscores the point that there's a lot of state variability. It shows that offense patterns vary widely across states, which means that there are policy choices rather than inevitability of someone staying incarcerated simply because of the type of crime. So how and whether people grow old in prison is the result of sentencing laws, parole practices, and release mechanisms. And that means that it's something that policymakers can change. So, all right, so we've now portrayed who these people are, why they're there, how long they've spent there. Let's turn to a discussion about what kind of harm they're experiencing while they're incarcerated. And elderly people are really experiencing very distinct harms. First of all, they have higher rates of chronic illness than both younger incarcerated people and compared to their peers in the community. Prisons often lack the staffing, the expertise, and the resources to provide them with adequate care, which makes them ill equipped to address serious and chronic physical health challenges. The prison environment itself has been shown to exacerbate existing medical and mental health conditions. Mental health services are scarce in prison, and untreated symptoms can result in self harm or suicide. There's cognitive challenges such as dementia that make it difficult for older people to follow rules. That often leads to disciplinary actions against them, their placement in solitary confinement, for example. And those disciplinary actions often fail to account for cognitive impairments, and the sanctions that they face can really worsen their health and safety. Functional impairments on the part of the elderly limit their ability to keep up with daily activities. So think about tasks like climbing to upper bunks or standing in long lines or even chewing food can become very physically taxing. And yet, prison routines very rarely accommodate those kinds of limitations, which really compounds the difficulties of daily life for elders in prison. The facilities themselves they make housing and services and programs physically inaccessible, which leaves older incarcerated people unable to fully participate in daily activities or even to access necessary care. One thing that people don't think about is how older incarcerated people face heightened risks from heat and cold and storms and wildfires and pandemics. Of course, the COVID-19 pandemic illustrated that vividly. Despite being a much smaller share of the population, elderly people accounted for the overwhelming majority of prison deaths. There was one prison in Texas that houses primarily elderly people, and 6% of that prison population died from COVID. The bottom line here is that prisons were not built for people who are growing older, and the resulting harms that elderly incarcerated people experience compound over time, which creates very severe risks to their health, to their safety, and to their dignity.
Okay.
So with that, I'm going to ask Alycia to take over and talk about the next issues.
Yes, thanks, Michelle. So given these harms, we wondered how elderly people fared after they were released. Figure 15, you see on the slide, shows a critical and often unappreciated reality that elderly incarcerated people are among the least likely to reoffend. Our own survey data of state prisons revealed that very few states track recidivism by age, particularly by single years. But the data we were able to gather from Colorado, South Carolina, and Florida paints a striking picture. The 3-year recidivism rates for formerly incarcerated people aged 50 and over are dramatically lower than the national 3-year rate of around 66%. In Florida, for example, you can see the rate is just over 6%. So these findings bolster what is now well-established research showing that people age out of crime, even after serving long sentences for violent convictions. And this really makes them an ideal population for release. Next, we wanted to better understand the fiscal impact of housing elderly incarcerated people in prison. One challenge in understanding these costs, though, is that there's no reliable, up-to-date national estimate of how much it actually costs to incarcerate elderly people, as Michelle mentioned at the outset. So while it's often cited that elderly people cost 2 to 3 times more to incarcerate than younger people, that estimate's based on decades-old data. No comprehensive national fiscal analysis has been conducted in more than 20 years. Because most states do not report age-specific costs, we compared changes in the share of the incarcerated population over age 55 with changes in per-person incarceration costs over time. As you can see on the slide, Arkansas and Utah are provided here as examples of our state-by-state analysis. In both of these states, increases in the elderly population closely track rising correctional spending, even when the overall prison population declines. So the findings suggest that elderly incarceration truly is driving the costs and is extraordinarily expensive. So then we then asked ourselves what drives these higher costs. And of course, without up-to-date national data or even state-by-state data, we weren't able to identify all of the factors driving these higher costs. However, because older people have higher rates, as you all know, of chronic illness, disability, cognitive decline, and complex medical needs, they utilize correctional healthcare systems more often than their younger counterparts, suggesting that healthcare costs are primarily driving the higher costs for this older population. And while we requested age-specific healthcare spending data from all 50 states to no avail, we developed an extremely conservative estimate using publicly available data. So figure 18 shows our estimates of medical costs attributable to the aging incarcerated population in 4 states: Alabama, Indiana, Florida, and Texas. And even using this lowest end estimate, medical costs for elderly incarcerated people rise sharply over time in every state that we examined. These trends underscore yet another critical point that as the prison populations age, correctional systems become increasingly expensive to operate, which means aging incarceration is not only a moral and public safety issue, but it truly is a growing fiscal burden on state budgets. So, given the immense fiscal, operational, and human costs of aging behind bars, the next obvious set of questions for us was what mechanisms already exist to release elderly people from prison, and why aren't those mechanisms working? Most states have compassionate release programs, also known as early release programs, and some states have second look mechanisms. But in practice, both mechanisms rarely lead to earlier release for elderly people. Compassionate release is often so medically restrictive, procedurally confusing, and slow that people die waiting for a decision or are just categorically excluded altogether. Second look review, while promising, typically applies only to people sentenced as juveniles or operates prospectively, leaving most elderly people sentenced as adults with no path to review. The result is a system where relief might exist on paper through these mechanisms, but not in practice, and where the elderly prison population continues to grow despite these mechanisms existing. Now, even when elderly people are released, communities are often unprepared. Formerly incarcerated people are far more likely to experience homelessness than the general population, and that risk is even higher for older elderly returnees. Many have been incarcerated for decades and simply have no family, no home, and no community to return to. Medical placement, when it's needed, is another major barrier. Virtually no state-funded nursing homes will accept formerly incarcerated people. And nationwide, there are only 2 facilities that specialize in caring for elderly people after incarceration. Even when services are theoretically available, accessing them is extraordinarily difficult. So older returnees often face complex Medicaid and long-term care enrollment processes after decades of confinement with little or no professional assistance to help them navigate these extraordinarily complicated systems. And many traditional reentry housing programs are just functionally inaccessible. Halfway houses often cannot accommodate people with mobility limitations or serious medical needs, and many require employment as a condition of placement, automatically excluding people who are disabled, chronically ill, or physically frail. So without housing, healthcare, and support, how are elderly returnees supposed to make, truly a successful transition? So we asked ourselves, what's to be done to reverse the crisis of aging behind bars? We developed 3 sets of recommendations, and those recommendations provide a roadmap forward. They're organized into three broad categories. The first is reducing the number of elderly people in prison. The second is supporting successful reentry. And the third is reducing harm for those who remain incarcerated. Across all three categories is a foundational need for better data and transparent cost analysis. Without accurate data and transparent cost information, it's impossible to design effective policy or truly hold systems accountable. These gaps inform every recommendation that I'm about to describe and that we outline in detail in our report. So the first set of recommendations focuses on releasing more elderly people from prison. This is the most important reform in our report because doing so advances public safety, it reduces correctional spending, and it allows states to redirect resources toward community-based solutions that are far more effective for this population. States should make compassionate release actually work as a back-end release mechanism for elderly people with serious health needs. We recommend broadening eligibility, eliminating offense and sentence-based exclusions, and removing rigid medical thresholds that delay release until it's effectively too late. Allowing incarcerated people to petition courts directly with access to counsel would also make the process more timely, more transparent, and more accountable. Another pathway is geriatric parole for older people who are not terminally ill, but who are no longer a serious risk to public safety. Geriatric parole policies should provide consideration once someone reaches a specified age and has served a meaningful portion of their sentence without requiring a medical diagnosis. When structured broadly and without categorical exclusions, these policies allow age and time served to meaningfully factor into release decisions. More broadly, parole decision-making itself also needs to shift. Release determinations should prioritize forward-looking factors, such as current age, institutional behavior, demonstrated rehabilitation, and reentry readiness, rather than focusing almost exclusively on the original offense. Parole boards should also receive training on aging, disability, and the well-established relationship between age and declining recidivism. And their decisions should be more transparent and subject to meaningful review. Now, none of these reforms can succeed in isolation if sentencing laws continue to funnel people into decades-long prison terms. More states should enact second look legislation to provide an opportunity for judges to reassess long sentences imposed as adults, retroactively and without categorical exclusions, based on who a person is today rather than who they were decades ago. States should also revise and reform mandatory minimums, three strikes laws, truth in sentencing requirements, and parole abolition policies. All of those policies Michele identified early on, and which contribute directly to the aging crisis. Replacing them with sentencing frameworks that allow for periodic review and meaningful opportunities for release as people age is truly essential to sustainably reducing the elderly incarcerated population. Our second area of recommendations focuses on addressing the complex reentry needs of elderly people. Reentry needs to begin before someone leaves prison. And we recommend services for elderly people start at the very least 90 days prior to their release and be structured as comprehensive and individualized reentry planning rather than optional or piecemeal programming as happens in so many prisons now. Services should include one-on-one counseling, future planning workshops, help obtaining essential identification documents, healthcare and public benefits enrollment, housing navigation support, and access to peer mentors who understand the challenges that elderly incarcerated people are facing. Additionally, states need to significantly expand reentry housing options that are specifically designed for elderly returnees through coordinated efforts across multiple entities, including corrections, healthcare, social services, as well as partnerships with nonprofit providers. Models that integrate housing with medical care, supervision, and reentry support, such as transitional care or skilled nursing facilities, show how these systems can work together in practice. Now, even with stable housing, many elderly people need ongoing support once they're back in the community. So states should establish non-residential community reentry centers specifically for elderly returnees living independently or in transitional housing. These centers should operate as drop-in hubs that provide flexible, ongoing support after release, including technology assistance and digital literacy training, connections to healthcare providers and telehealth services, referrals for mental health and substance use, peer support groups, opportunities for social engagement, and help finding employment for those who are able to work. Finally, our third set of recommendations focuses on ways to reduce harm to elderly people who remain incarcerated by aligning prison policies, medical care, and facility operations with community standards of care and the realities of aging. And that begins with medical care. Prison agencies and policymakers should expand access to appropriate medical care for older people through regular preventative assessments and individualized treatment planning. This includes routine screenings for chronic illness, disability, cognitive impairment, mobility limitations, sleep disturbances, and sensory loss. It also means allowing people to plan for the future. Corrections departments should amend institutional policies that restrict advanced care planning in prison. Incarcerated people should be supported in documenting their medical preferences and end-of-life wishes, including through access to living wills, to notary services, and clear information about their diagnoses and treatment options. Additionally, prison agencies must ensure full compliance with the Americans with Disabilities Act by ensuring incarcerated people can access housing and medical units, work assignments, visitation spaces, and other physical locations within a facility by making reasonable accommodations for mobility devices, for hearing and vision impairments, and for medical equipment, such as CPAP machines or oxygen. Housing assignments should prioritize proximity to essential services, and staff should receive training on disability rights and accommodations. Prison agencies must also adapt their emergency and disaster protocols to account for the heightened vulnerability of older adults. This includes maintaining indoor temperatures at safe levels year-round, as well as planning for evacuations and emergency responses to account for the needs of elderly people. Reducing harm also requires changes in daily supervision practices. Staff should receive regular training on interacting with older incarcerated people, particularly those with cognitive or physical impairments. They should also be equipped to recognize age-related changes, respond appropriately to confusion or sensory loss, things that are very specific to elderly people. They should identify signs of abuse or exploitation and rely on de-escalation strategies rather than punitive discipline policies, punitive discipline practices. Older people should not be assigned work that exceeds their physical abilities, and certainly not then disciplined for not being able to participate in those work assignments. Strong oversight and accountability are essential as well for maintaining these types of practices. States should establish safe reporting mechanisms and strengthen independent oversight to ensure elderly people can report harm without fear of retaliation, and that agencies are held accountable for meeting standards of care. For those facing serious or terminal illness, access to hospice care is critical. Prison agencies should establish or expand hospice services and peer caregiver programs, and prioritize compassionate release to community-based hospice whenever possible. Where hospice occurs inside a prison, it should involve multidisciplinary medical teams, trained peer caregivers, and supportive visitation policies. And finally, prison agencies should address the growing prevalence of dementia among this population. This requires establishing dedicated memory care units staffed by trained professionals and supported by peer caregivers, with housing designed to promote safety, dignity, and appropriate care. Where feasible, these units should be located in community-based or medical settings rather than high-security prisons. So taken together, all of these recommendations and reforms provide a comprehensive framework for protecting elderly people who remain incarcerated, reducing preventable harm, and ensuring that aging in prison does not mean aging without care, dignity, or basic human protections. We are now happy to turn it over to you all for your questions and comments. We'd love to hear from you and hear any feedback you have.
Thank you so much. So first of all, just to say, the exciting part about this for us is that we're the researchers. I think everybody sitting in this room are the researchers who created a lot of these data, and some of the people in this room are the people who've lived these conditions. And so it's nice to see the ACLU in particular as such a big and important kind of organizing body in the nation take on this issue and sort of get some of our research right. That's really, really nice. And I guess what I would be curious about, and I know Jen was going to lead this conversation because unfortunately I have to run out for mandatory meeting in a couple minutes. But in 10 years, when you write this report again, or in 12 years,
When someone does.
what are the things that you wish that you knew now? Because this is the group that's going to do that research. Um, what are the things that you feel like are the low-hanging fruit that were so unbelievable that it was not known? And like, where do you think the most important places are for our groups and our group to kind of attend to?
Well, I know that one thing that we felt is sorely lacking is the financial information, the fiscal information. Whether this is the right group to do it or not, I don't know, but there really needs to be a national analysis that can pinpoint the costs of this population. And we were not able to access anything like that. And we feel like that would be a very, very powerful data point.
And I think two parts to that gap Michelle's naming. One is advocating to ensure that corrections agencies are required to report the costs on this population. What drives the cost? What are the costs, first of all, for this age group, and what's driving those costs? And then for researchers like all of us here, using that data immediately once it's out to analyze and show policymakers what kind of rich analysis they can get from that type of data. And ensuring that continuing to report that data, happens over the long term, that it doesn't just stop because, for this period of time we're focused on the elderly population. It really needs to continue for the foreseeable future.
That's super helpful. I want to make space if others have questions. Oh, Jane, go for it, Jane.
Hi, thank you. And I so appreciate your report. It's a lot of really great information. The question for me is how do we impose it on the people that have the ability to make these changes? Things like, in California, we have the elderly parole policy, which applies to everyone over the age of 50. So they can go up for consideration for parole. But it's only now in the last couple of years that the rate of success of those parole hearings even came close to measuring the overall rate. So that's just ridiculous, that we don't take into consideration, or the commissioners don't take into consideration, all of the research that says this is the safest population to release. And, yet they're denied. Finally, it's about even. They're being granted parole about evenly as the rest of the population, but it should be 2 or 3 times greater. It should be. It just makes sense that way. Simple things too, like the requirement that everyone who's incarcerated has to work. Having spent 20 years in prison myself, I went in at age 53, came out at age 73, and thanks to the work of the Innocence Project, I'm now an exoneree, and the passion I had for working in community mental health has been translated into working for criminal justice reform. But there are so many simple things that could be done, like requiring elderly to work. I've seen so many women who are in a wheelchair or a walker, and they're being forced to push brooms around or mops. It just makes no sense. And anyway, I realize I'm preaching to the choir here, so I'll move on.
Those are great points. I think so much will depend on the ability of advocates to get information to policymakers about the low risks presented by this population and the how one of the reasons we wanted to gather information about how long people had spent in custody is because they've already been punished, right? It's not like these are people who are getting out at a very early stage. They are getting out. If they are released, they will be getting out having served decades. And I think that that's important for policymakers to understand as well. The low risks, the fact that punishment has already occurred, and the fact that there's many, well, also how expensive the population is.
And how little of a return on investment there is, right, for the amount of money that we're spending. And I think your question in terms of strategy, you know, we all that are well versed in these issues and focused on this population need to sort of align our strategies, right? So that is one way to look at this, right, and identify the problem. But I think we also need storytelling. We need people to share lived experiences. We need to be able to connect to the heart of policymakers, and continue to have research on everything that we're showing here. And then be able to show what policies are working, right? Where there are policies across the country that are helping to reduce the population or better support them in the community, we need to really sort of blast information about those policies, and encourage those policies to take shape other places. So aligning all of those things together, I think, is strategically beneficial.
That's where I was kind of going with the reentry side of things. I mean, I really liked your presentation on reentry, but I think even Jane can admit there was a lot of mental trauma after 20 years in prison. Call it the Shawshank effect, call it whatever you want. I've worked on a presentation here in Oklahoma on reentry of the elderly, but it's more based on the mental health side of things because of what they've had to experience in prison. My problem is there's really no research in that area. There's no programs really in that area. I did see one that I'll look into, but nothing that, we need to think about. Nursing homes don't really like usually taking this type of population, with some exceptions. That's kind of where I was going. So we have, we get this steam up to let them out, but family members have died, family members have moved on. Obviously, usually mom and dad have passed on. That's where I'm going with this whole thing, is what do we do on the backside? Do you have any comments along those lines, maybe? Thoughts?
Yeah, absolutely. In our recommendations that we outlined specifically in that third, I'm sorry, in the second set where we're focused on reentry services for elderly people. I mean, communities have to take a hard look at the policies that restrict formerly incarcerated elderly people from accessing those services. The fact that someone's crime would bar them from being able to access safe medical housing, at nursing facilities is sad. It's alarming. I mean, we're truly setting people up not just for failure, but early death, right? I mean, that should unnerve everybody. Um, and that's just one example. There are other ways in which all incarcerated people are restricted from access to cash assistance, food stamps, support for maintaining and reestablishing relationships with family. There's so much that we need to take a hard look at, and that's why we try to emphasize a sort of multidisciplinary approach to these recommendations, because it's not just corrections that needs to adjust how they're doing things. I hope that answers your question.
It does. It's. I think we have to begin to figure out who we reach out to. I mean, it's not always the crime type. It could be the fact that the person may have dementia, and just even finding a place for dementia, and then you throw any kind of crime. It could be anything from burglary to murder onto that, and it just automatically they're like, yeah, no, we're good. And that's kind of where I'm going with this. We have to try to figure out how to address the overall picture.
Yep, absolutely.
For sure. And luckily, I mean, we have like several folks in our network who've been researching this, who are sort of looking at nursing home acceptance of folks coming home. So I'm hopeful we'll continue to know more. We can drop the latest pub from that in the chat in a second. Um, yeah, thank you both so much. I really appreciate you taking the time to share this report, and I'll echo what Bree said. It was great as I was just like looking through the report and the reference list, the overlap with people in this room and the reference list is really high, which is so exciting to see. And I hope that you all will keep in touch with us and help us think about how best to shape our research to have policy impact, and how best, to think about making sure our priority areas are sort of aligned with the type of work you do in these reports that have such a big impact. So thank you both. Thank you all so much. Round
Thank
of
you so much for
applause.
having us. We really appreciate
Thank you all so much. And thank
And
you
we're
for the work
grateful
that
for your
you're all
work.
doing. Yeah.
Absolutely.
All right, we'll transition to our next speaker. We're going to have Amanda Emerson, longtime Arch Network member. Amanda's an associate professor at the University of Kansas Medical Center, and she's going to present on two ongoing projects: an engagement capacity building award from the Patient-Centered Outcomes Research Institute, and an intervention development project funded by the Gordon and Betty Moore Foundation. So, Amanda, hand it over to you.
Thank you, Jen. Let's see. Okay, so continue to share this PowerPoint. Yes. Great. Thank you for having me today. As Jen said, I've been a member of Arch for a while, and I have presented in works in progress before. And so I found this old slide from 2023, which was the last time I gave a works in progress talk. And I thought it was interesting to think about sort of the trajectory where this work has gone. And so this is just an updated slide that starts with the Arch pilot grant that I got in, I think it was 2020. I think it was the first round. It might have been the second. But it was to look, I had been doing work with Megha Ramaswamy's team on cervical cancer prevention and women who are incarcerated. We did a jail-based empowerment and education program in Kansas City. And I took that when I was getting older myself. So getting in my late 40s, early 50s, and a lot of the women that we had been working with were as well. And so I started thinking about, what is sexual health like for women who have been incarcerated and are not incarcerated now? And so I did a small interview study, but that led to some other things. So I had a KL2 that Bree was a mentor on, that used HRS data to look at women who had been incarcerated and women who had not been incarcerated to see what the major health differences were, and then had those results as well as a scoping review and some other things. And we also did some interviews with women and with service providers across several states to look at what it looks like to get services after incarceration if you're an older woman, which, as the last talk made clear, getting services after incarceration can be tricky anyway. If you're an older woman, sometimes they can be even trickier. And so it's a kind of an even smaller population, and a lot of the programs, for funding reasons, often will have beds for men, but not for women, because there's such a small group, and there just are very few tailored programs. So during that KL2, I had applied, I submitted an R01, and that's that phase 3 in the middle. And I'll say just a little bit about that, but then the phase 4 and phase 5 are actually what I'm going to talk about today. So phase 3 was or is an R01 proposal that I initially submitted in 2023 to examine how incarceration impacts aging-related health. The overall design is parallel convergent. It's multiple methods, so it's mixed methods. We have a AIM-1 that looks at HRS data like we did in phase 1. We're using that as a control, though. Those are women who have no experience of incarceration. And then we're enrolling 300 women and following them over a period of 3 years to measure functional ability change. And so functional ability is like a composite of intrinsic capacity and then some social and physical environment factors. We're also surveying on criminal legal system involvement because in the HRS, there's not a lot of granular data about that. So we were interested in what kinds of developmental life course changes happen during an incarceration and how those might intersect with the effects of incarceration. So the big pictures, we're trying to look at how incarceration acts as a social determinant of health, and trying to do that with empirical data. But the second aim then is an interview aim. We're doing interviews and ethnography. And so we'll bring those together and see how they speak to one another. So that was submitted in 2023 and then scored but not discussed, and resubmitted in February. And then we got this amazing score last July, which I didn't think would go any further, but I did get a just in time on December 16th. So yay for us. And that includes Jennifer Lorvik, who's on this call because she's a co-investigator. So she's the Oakland site. We're doing it in Kansas City and Oakland. So yay for that. I'm not going to talk much more about that because I don't want to think about it right now. I'm kind of scared. We haven't heard anything more. So it may or may not happen. So what I want to talk about today, though, is phase 4 and phase 5. And phase 4 is a PCORI engagement capacity building project or award that I received. It's 24 to 26 to develop readiness and interest with older women, community advocates, and healthy aging researchers for engagement in comparative effectiveness research that is focused specifically on frailty, because that was the number one finding that we had from the phase 1 study with the HRS data, was that women who had a history of incarceration had much higher rates of both frailty and pre-frailty. So that's kind of the focus for the engagement capacity building program. The project is concentrated on creating community awareness and learning around patient-centered outcomes research, and then also about frailty. So we have these 4 parts that we're doing, which is sharing, learning, teaching, and outreach with the women. There are 6, it fluctuates between 6 and 8 women over age 50. They have to have at least a year's experience of incarceration. I think it ranges from 25 months to 25 years. So it's a pretty broad range. And the women themselves, we did accept one person who was 48, so it's 48 to 70. So again, like age-wise, we have a pretty good range too. There's 2 community advocates in Alhart. There's a healthy aging researcher who does sleep research and a geriatrician who works in the community. And then we also have 5 project team members. So we mainly are finding ways to build awareness, means, and opportunities for women to be involved in research at all stages. And so really helping to generate a groundswell where women are identifying the priorities for research and collaborating with local researchers to try to get some stuff off the ground. So I'm just going to go over a couple of the ways in which we run this program. The sharing aspect of it is really around us sharing with one another the experiences, so creating a sense of community, but also sharing what kinds of needs women have coming out of incarceration if they're older, what kinds of aspirations they have. So sharing that with one another, but then also sharing it with the community. We started by doing some work just to find out about one another. We did a power wheel to figure out, what are some of the perspectives that we have in the group that are missing. So what kinds of things might we need to go outside the group to get ideas about? We also did a trauma-informed community engagement guide. So working with community groups who might have trauma in their past, we developed a guide based on these 4 pillars. So people, power, place, and I just forgot the process, and sort of brainstormed with the women and developed this guide that we then submitted to PCORI, and it will be in our website. We also did some work generating ideas about what frailty and health looks like to women after incarceration. And then we used that to generate an interview guide that we used in another part of the project where we did listening sessions in the community. So they helped us create the listening guide. And then once the listening guide had been developed, I did the interviews. We de-identified the data. We brought it back. We did analysis together. So part of this project also, there's the sharing aspect, and then there's also the learning aspect. And so in this part, we use the listening session guides to then come up with some ideas about what this looks like in a broader sense. We hired a graphic recorder to do a project summary for it, and that's what's on the screen. We also did some education with the women around research. And so we did a frailty self-study where everybody went through the steps of a Freed Frailty Index, or is that right? Index? We did the 5-meter walk and the grip test and answered questions about vitality. And then as a group, we took all the data, which was de-identified, and tabulated it, and in groups added it up and figured out what that looked like. And then we worked together on a slide set that teaches about research itself. And so this is one of the slides from that slide set where we used the data that we had developed as a group, which is in that left-hand slide, and talked about what a frailty score means, what it means in research. So we talked about samples and populations. And it was interesting that our frailty score, so our pre-frailty score, was actually 60% for the group, which is interesting because that was the pre-frailty score from the HRS data as well, when I did that study for phase 1. So it was interesting that it matched up, and it was a nice lesson for sample and population. On the right, that earlier with the Post-its, we had talked about qualitative research and how you generate qualitative research. And so this was just a guide for helping us talk about that. So then we also talked some about comparative effectiveness research, because as part of the PCORI project, that's kind of what we're working toward. And so taking what we had learned in the first part and starting to think a little bit about what that might look like to develop an intervention, or to start to compare interventions for outcomes that are important to the women. And so the second project, which is different from what I had in mind in 2023, the phase 5, I'd written an R21 that was a research plan for a physical activity intervention that was kind of styled after the VA's GeroFit program. I don't know if people are familiar with that, but I developed this idea, but then I set it aside. I got some funding from the Gordon and Betty Moore Foundation as a Irene Moore Nurse Leaders and Innovators Fellow. And so the project I proposed was WISHA, and that's what appears on the screen there. And it was to develop a facilitated reentry program or tool. So we're moving to the intervention part with older women to provide support during reentry to the community. So I put aside GeroFit. I wanted to build more on the community participatory methods that I was using in PCORI. And I proposed an equity-focused human-centered design project in which my team would work with a community-based research team of older women with LEI, lived experience of incarceration, to design and preliminarily test an app or program that's tailored for older women after incarceration. And my team brought together this group. So they're the Women Initiating Support for Healthier Aging, WISHA. It was, again, equity-based, human-centered design. We had 10 women. 5 of them are also in ALHEART, I should admit. But there are 10 women age 50 or older with lived experience of incarceration. We followed the human-centered design process. So our first aim was to empathize with the population, which they are the population. So that was pretty straightforward, to define the problem, then to prototype some solutions. And then our second aim was to test the solutions and prototype further, so develop and refine, and then another cycle in the third. And I'll talk about each of those. So this is just a picture of what that human-centered design process looks like. And we did education on this and went through this whole thing. And it's actually a lot simpler than it looks. But I mean, the idea is that you start out really broad, empathizing and exploring, and then you narrow down and you define a problem and maybe a possible solution. And then you broaden back out to imagine and ideate what that would look like and how you can do it. Then you create a prototype, and then you narrow back down and test and select, and then you cycle back around. So that's what WISHA has been doing for the past year and a half, basically. So we began with this empathize and explore. We took the 10 women right off the bat. We got them to come to a 2-day, this was 10 hours retreat, where we did a number of different things. We had an empathy mapping session So that, we had to figure that out and define it and everything. We did the empathy mapping workshop. We did a 90-minute listening session. And that was helping us to kind of define things. And then 3 small groups, we did some education around prototyping in 3 small groups, each built a 3D prototype of a program or tool that they felt would be especially valuable to older women coming out of incarceration. So the big group got together and looked at that. So these are the original prototypes that they built. Then we went table to table and each group presented their prototype and talked about, why it's important and what it would do and so forth. And we asked questions and recorded all of it. Then we sent these with the comments to our technology consultant who asked more questions. So then we met again and we did some more prototyping, went through a second round. They made revisions. I said, in true human-centered design process, I did say you can scrap it and start over, but nobody did that. So we all kind of stuck with our same projects. The one on the left was a analog. So this was the only one that was not an app, but the one on the left was a community based clothing basket program for women coming out of prison, because that was one of the needs that the women felt was really important. There were a lot of women they knew who were older who came out. They not only didn't know the styles, but they just didn't have any access to getting the clothes. So first thing, getting a clothing basket with other kinds of supplies in it from their at the probation office, which seems kind of tricky, but that's where they thought it would do the most good. And then there was a housing connector program or prototype that would help women get connected with a peer who had been through the process of finding housing after incarceration, who'd be able to give guidance. And then the third one was a peer connector. And so it was a much broader focused. And then they had like a list of different things that the peer connector would help with. So after we did that second round of prototyping, took it back to the tech consultant and he built them. So just real mocked up low fidelity prototypes as apps that you could actually use. So the Housing Liaison, I think I called it connector, but Housing Liaison Award Program, the Peer Coach and Resource Connector, and the Clothing Basket, which we just put together. And so the second aim was to test. So we took these prototypes, and with the women, we scripted demonstration videos and filmed them. So the women acted in them. We did all the scripting together. The filming was fun but painful. It took a really long time. There were lots and lots and lots and lots of retakes. But we got those put together, and then we are testing in the community with 40 people. So we're aiming for 30 women, 5 community advocates or clinicians in the community, and then 5 people from the legal courts and law enforcement sectors. So they see all 3 videos and give feedback and also do kind of a best in show choice. And so the next stage will be to then come back with what we find out and bring it back to the group to analyze what we hear and to make a decision about which one we'll go forward with. So we'll eventually choose one, and then that one will develop and pilot. So that would be the next project. And I think on that first slide, there was a piloting R21 over on the right-hand side. And we're in the middle of this right now, so we still have 21 women that we need to recruit for this. Aim 3, which should start in July, is the next step. So once we have a high fidelity, once we've chosen a prototype and we revise it, we have a high fidelity version, then we'll do this next step, which is a user testing with 16 people. We have the high fidelity prototype. I'm guessing it will probably be one of the 2 apps. And we will do 2 rounds of what's called Think Aloud protocol. So they will actually use the app, and we'll give them like things to do, find breast cancer screening or find access to some resource. And then they'll use the app and as they're doing it, talk about their feelings and thoughts and where they're getting stuck out loud. And that protocol usually gets recorded, which we'll do. And then we also have permission. I'm a little on the fence about this, but doing eye tracking, which is it's industry, common, but I'm not sure the women are going to like it. So we're going to have to figure that part out. But it just tracks eye movement as people are using an app and figures out where people are getting stuck, where they keep coming back to, that sort of thing. And so the use case testing, we also do some interviews as part of that to see what the experience of using the app was like. Was it acceptable? Was it something that they would recommend to others? That sort of thing. That's the honeycomb up in the right-hand corner. And then do the data analysis there, and that will guide that final product so that when we go for an R, we'll be able to say we've done all this preliminary research. And then our outcomes would be things like health resources use, health systems navigation, literacy, and health itself. And so we also have three surveys for those that are in this AIM-2 interviews that we're doing right now, just so we can time how long it takes to do them and get some feedback on the acceptability of those measures and whether the questions made sense and that sort of thing. But this is where we're at, not at AIM-3, but where we're at in terms of these programs. The whole impetus here was to get programs that didn't start with me having some information and then getting funding and going and doing something, but trying to get from the ground up what was important to the women and what they wanted to work on, and then figuring out methods for making that happen. And so far it's been pretty successful, and I think it will be useful going forward so that when we do things like having community advisory boards, they're a little bit more than just saying, hey, this is what we're doing. Do you think it's good, right? That people can actually be involved in the process of the research and feel like they're invested in it and it's coming back to them. So that was pretty short. But the ALHART is a Patient-Centered Outcomes Research Institute Award, and the WISHA, again, is the Gordon and Betty Moore Foundation. I would just say thanks to the women from both projects and what I'm informally calling the Free Women Rising team, which is my lab. And then the people who are on that team follow. So thank you. I'm happy to answer any questions.
Thank you so much. I'm just like incredibly in awe of your methods and the way you engage people and the types of products you produce. Like, it's just like so exciting. Like, I feel like you had 17 really exciting visuals of the stuff you're doing in one presentation. So I'm just like so continually blown away every time I hear about your work.
Thank you.
Yeah.
Likewise.
Um, I could totally ask questions, but I don't want to take up space if other people have questions. Oh, does somebody come off mute to ask a question? Please do.
So is the ultimate goal to eventually have an app that they can use upon release? Is that basically the final goal? Is that the way I understand it? Just one app?
For the WISHA project, yes. Yes. And based on what we're hearing in the AIM-2 interviews, it's probably going to be something having to do with that peer connector. And likely because the resource part of it, which is always the most important thing for the women, I don't know why there's feedback, the most important aspect for the women, that part of it will just be one part of it, like the community, building community, I think part of it's going to be strong too. Because even though when we talk about what do you need, it's always resources. When we talk about what the women are getting out of these groups, it's always community. And so bringing those two things together really is really important, I think, not losing track of that aspect. But yes, an app or a tool.
And you think eventually, maybe over time, this could be moved to a men's type of deal too?
Oh, sure.
Okay.
Yeah. I would think that I almost think it would need to be repeated with men, because the idea is that it's being generated by the population that uses it. And to the extent that women have different hurdles sometimes after incarceration, it might be good to do it with men too. Yeah.
Do you kind of have a final timeline on when you might actually have the app live for the public, or is that just ballparking it, or still ways out?
Well, we should have something usable by the end of the project, which would be the summer of 27. And then I'd want to pilot it. So it would probably be 29, unless I accelerated it. I mean,
Good to know. Do you is this going to presentation be put on line where we can get it or have access to your email or contact information if we wanted to get back to you, touch it in the
yeah,
future?
I can certainly make it available to you. I will put my contact information in the chat.
And just for everyone to know, we do, after these presentations, ask the speakers if they're okay with us posting on our website. And so if folks are, then they do end up living on the website. So if you want to share with any of these with a colleague another time, as long as our speakers get permission, they often end up there. So FYI.
One thing I would comment on that occurs to me right now, and I actually had it in the written part of this, but we have also been trying to disseminate with the group. And so we've presented at 2 local conferences, done co-presentations where the women come to the conference with us, which, wow, like that is such a great experience. And I had written into the grant to bring somebody to ACCJH. And I don't know if it's going to happen because institutionally figuring that out, like how you get that payment made is pretty difficult. But if you can swing it, it's so great to, the work is co-work. And so why wouldn't it be co-presented? That's important. And we have written an article on the methods from Owlheart, which I submitted the revise and resubmit to the Journal of Clinical and Translational Sciences at the end of December, so we're kind of waiting on that. Next week, we filmed the video for the website. So we have an introductory video that the women we were trying to get volunteers. I think the experience of doing the other video was kind of traumatic.
Other questions for Amanda or other things, Amanda, that you'd like advice or feedback on as this work continues?
I mean, I definitely think there's a lot to be worked through in terms of maintaining interest and involvement. Like that's just a methods hurdle that no matter how great the program is, at some point people start, the novelty's gone and people have better things to do at 6 o'clock at night or whatever. And so figuring out a way to reinvigorate, I think that's going to be part of the next set of methodological challenges anyway.
I have a question on the women. What's some of the mental aspects and traumatization you may have seen from their years of incarceration? I assume many of these women spent quite a few years in prison. Can you maybe just touch briefly on that?
Yeah, so when we did our listening sessions, one of the top things that came up was just this idea of fear, that there's a lot of fear coming out. Women don't know what to expect. They don't know what the world looks like at this point. So there was fear around just how do you live outside of this really intense structure and schedule, and making the adjustments from that kind of context to one which feels just way wide open. And so women had a lot of insecurity around just making that transition. Also, finding ways to heal or fit back into family. There was a lot of conversation about that, and people's children having expectations that they weren't able to meet, or feeling like they couldn't fill a role as a mother anymore because their kids weren't recognizing their motherhood, and like that was a whole transition as well for a lot of women. I would say another one that came up a lot, and I just remember this one phrase, like, I don't have my girls anymore. And like there's a sense of community, for as awful as prison is, going through this really intensive traumatic experience with other people, coming out and being around folks who just don't know. Like I don't know. And this comes up a lot. They're like, you weren't in prison. And so having a community of people who are supportive and positive and do know, like that's a big thing. So isolation, I guess, or just feeling like you don't have a tribe, maybe. I don't know. Those are the main ones that come to mind. Another one that also came up a few times was you build a way of responding in prison or like shielding yourself. Women talked about just in like a minor conflict situation, going from 0 to 100, just because that's how they were used to socializing in that context. And so figuring out how to not do that.
Yeah, breaking through that emotional wall. That's what I talk
Mm-hmm.
about a lot with my people. They put up such a strong emotional wall
Yeah.
that it's hard when they get out into society to be able to break that wall in some way, shape, or form.
Yeah. That's right.
Any last questions? I'll ask just one small one. I'm so curious about your experience with like graphic note taking in these contexts. I've like been in meetings where it's done and I always think it's so cool and I never actually like pay the money to do it for stuff. But did you think it was worth it? What did you think about it? How did it go over having someone sort of do that?
Yeah. And that was PCORI, so it wasn't even
Yeah.
information capital. They were completely into that. And the person that we used, her name's Janine Burns, or Joe Byrne. It's See Your Words. She was fantastic. And she'll do
Mm,
live, like she'll travel or she'll do live
yeah.
online. We sent her transcripts and she did the graphic illustrations from transcripts.
Oh,
Um,
interesting.
and the women love them. And I think they're a really nice, creative way to present, to summarize what happens in a listening session. But we also use them, also made postcards with them. So we could use them for letting people know who we are and if they want to join. And then on the back, we have a sticker that they can contact us. We're using a little bit for recruitment too.
I'm
So
curious. I'm curious, since you're dealing with older ladies, was there any challenges on using cell phones and using apps and doing that type of stuff and educating them? Any funny stories along those lines, or something that was an issue?
yeah, we haven't had an issue with it, and amazingly, and I think some of them had not been using Zoom. We've met in person until December, I think. We met monthly in person since the summer of 2024. And then this past December, we started meeting on Zoom at least until March. And we've also had core teams, so those smaller groups that are on Zoom, and even the women who hadn't used Zoom before were fine. My project manager gets in touch with them beforehand and kind of goes through it, but we haven't had much of an issue with that. There were a couple of women who've told us about when they first got out. So one woman went into a pretty full wraparound program, transitional residential program. And so she told some funny stories about, somebody handing her a cell phone and she was like, what is this? And then she put it under her pillow because she was embarrassed that she didn't know how to use it. And then finally somebody showed her. So it's definitely, there's a learning curve. But I don't, I haven't heard very much about that. That was, one or two people. So I sometimes wonder but also a lot of our women are in their 50s and 60s. So they might, I don't know, they might just have more access um, to that kind of technology or something. It is an interesting question, though. We think about that sometimes with like the app, how is the app going to be useful to the whole broad range of women?
Sure. Well, we're at time. Thank you so much for this like fantastic presentation. Thanks to all of our speakers today. This has been great. Our next meeting is on March 3rd. We have another one in May. We have ACCJH. I think we still have a couple WIP slots open. So if you're interested in presenting or if somebody you want to hear from, please let me know. And yeah, thanks everybody. We'll see you soon. Be in touch.